Good morning, everyone. I miss seeing you all in person today, but I am glad that you are all home and safe and staying warm. What a winter we are having. I am going to talk about, give the lecture that I was going to give in class on skin integrity and wound care from chapter 33. As always, take a peek at the related course objectives. These will help guide your study. So the structures of the skin, you guys are already familiar with this from anatomy and physiology. Just make sure you review them if you have forgotten some things, because you will use this moving forward in nursing, not just in this lecture today, but also when we go to do medications and injections, you will need to be familiar with the layers of the skin. And there's a picture if you need to review it. We discussed the last time we met in class that skin provides our first line of defense against infection. So protection is just about the number one thing that our skin does for us, but it also helps keep our temperature regulated. Vitamin D production is huge, and we can absorb through our skin medications, nutrients, anything that we put on our skin that like lotion, we absorb that in, and we also sweat through our skin, right? We get rid of fluids, extra fluids that way. We help cool our body and warm our body. But the one that we're going to talk about all of these as we talk, but the protection and body temperature regulation are some huge ones as nurses. Things that can affect our skin, normally our skin should be unbroken, it should be healthy, it should be adequately moisturized, but not too moist, not too dry. Things that can affect our skin in negative ways are if we're dehydrated and our skin is dry and fragile and breaks easily, if we're malnourished and we're not able to rebuild skin cells as quickly as we normally would. If we have peripheral artery disease, our skin can get very shiny and taut, and we can have a lot of trouble healing because of lack of blood flow. Our skin might be pale. Think about folks who have diabetes. They have increased sugar. We talked about this last week, how bacteria love sugar, and not only do they have some elevated sugar, but they also have immune problems. They aren't as resistant to infection, and they're more apt to get an infection and not heal as fast when they have diabetes. So things like dehydration, malnourishment, comorbidities such as diabetes or an autoimmune disease or peripheral artery disease. What if someone's is elderly? Their skin's going to be thinner. It's going to be more fragile. It's not going to be as pliant as a healthy, normal skin. So what we do for this, think about your patients who are on bed rest and they're laying in one position for extended periods of time. This is one reason that nurses turn their patients regularly. We don't want to get an opened pressure wound on a pressure point, right? So we reposition frequently. We watch the pressure points. We make sure to keep them moving as much as possible. One of our roles is indeed to check the skin, assess the full skin frequently as nurses, at least every shift. Better yet, every time you reposition them, look at their skin. I always tell everybody that I know that in the clinical setting, we have a lot of folks who assist us, who help turn our patients, but at least once or twice a shift, you need to get your eyeballs on every one of your patients' bodies. Like, look at their back, look at their buttocks, look at their legs, look at everything. Even as you're walking them to the bathroom, you can look at their back and look at their skin. You need to be assessing this with your own registered nurse eyes, because if you have someone with a cast, think about people with casts, people who are on bed rest, people who have radiation that causes their skin to be more vulnerable. They can very quickly break down or develop an open wound. Make sure we hydrate and moisturize our patients as they can tolerate and as needed. That's what I will usually say to patients is I will say, just lean up for a minute and I'm going to listen to your lungs, and do you mind if I put some lotion on your back? So I'll have them lean forward, I'll listen to their lungs, put lotion all over their back, look at their coccyx area, have them lean as far as they can or turn to their side, And you can use it as a, number one, you're giving them a quick massage, a quick, lotion to the back, but you're more importantly, you're assessing it. You're looking at it and checking for tears, checking for broken, reddened areas. We're going to minimize our use of of tape. We're going to use paper tape whenever we can, and we're going to check patients frequently. Avoid harsh soaps. Folks who are older, have thinner skin, might need less frequent bathing. So your patient who's 90, who has very fragile skin, you're not going to go in there with some harsh soap and give them a bath every single day. You may give them some washcloths to clean up, and then the next day do a bath. The following day, just clean up the most important areas, their peri areas, their underarms, because giving them a bath every single day or putting them in a bathtub or a shower every single day will probably lead to them having more broken areas on their skin. So think about that with each of your patients. And you may need to teach them about not using such harsh soaps. The Dial that they used that's all harsh when they were in their 30s might just break open their skin now. So that's our role as a nurse, to teach that. And they may need to do less frequent bathing at home. And we may need to teach that. So I talked a little bit about the developmental considerations with elder adults, where they have decreased elasticity, increased risk for pressure damage, which means they're going to develop a pressure ulcer or a pressure injury much faster than someone who's younger. Just think about their circulation, their comorbidities. Their collagen's not going to replace as fast. Their skin is going to be thinner, not heal as well, and they're going to have more comorbidities. Children less than 2 years old, the skin is also very fragile. So think about that with any infants that you care for. Trying to think what else. I think we've said enough on this. But think about those developmental considerations that we should look at. One thing I didn't already mention was with folks who are either very thin or very obese. Those can also cause problems. If someone's very thin, their skin can be more fragile. They may not be nourished. And the same with an obese person. They may be malnourished even though they're obese. And in addition, the extra fat and the extra weight pulls on the skin. Sometimes the skin will sit, like you'll have skin folds that will sit on one another, and they are nice little areas for bacteria to grow and for moisture to sit, and then suddenly you look and they've got an open area. Look under the breasts for this, the abdomen. Lift areas that are folded so that you can see in there, and treat them with either some type of ordered lotion, or if it's a wound, we need to know about it and consult a wound care nurse or the physician to see what we can do to keep it from getting worse. So always look under folds. Look. You are the nurse. Look at everything, okay? Don't be shy. I always tell everybody, you are a professional nosy person now. So get in there and look at everything. Some folks, things that I didn't talk about otherwise were not just the delayed healing, the decreased elasticity, but think about the insulation loss if someone's really thin and or an elderly. And also in infants, when they don't have as thick skin, you may need to put more blankets on them, right? You may need to keep them warmer. Folks with certain comorbidities like liver disease have a lot of itching and dryness, and so the scratching itself can cause open areas on their skin. So be aware of that. Take measures to moisturize their skin and keep their skin balanced. And you may need to ask the physician for a medication for itching if someone has a comorbidity like liver disease that can cause them to scratch and open up areas. I'm trying to think what else. I think that was all I wanted to tell you about that. All right. So a wound, this is straight from your book. It's basically a break or disruption in the normal integrity of the skin. And these are the different types of wounds we can have. Sometimes when we do surgery, we have an intentional wound, a wound that we went in with a scalpel and we opened up that person's skin. An unintentional wound is something like a knife, well, I guess a traumatic It may have been intentional by someone who had bad intentions, but we think of things like knife wounds, or if you're in a car accident and you have a wound from that. Those are unintentional wounds. And when you think about these wounds, think about an intentional wound that we did in a surgical setting with getting rid of as many microorganisms as possible and keeping everything clean, versus they were in a car accident and they went flying out of the car and they skidded on the highway with their bare skin. That is going to have a much higher risk of infection. It's already got bacteria in it. It's going to have rough edges. It's going to be harder for it to heal because the edges are so poorly approximated. So think about that. And then neuropathic wounds often are from diabetics as well. Vascular wounds are wounds that often are from poor blood flow, peripheral artery disease. Pressure-related wounds we're going to talk more about on the upcoming slides, so I'm not going to talk about that right now. An open wound literally is what it says. It's we've done an incision and it's open, or they've had some kind of pressure injury where they've sat on one spot for a long time and they literally have an open wound, maybe on an elbow or their sacrum. Closed wound is something like if you ever had a lot of bruising, that's a closed wound. You've had some kind of hit to the area, some kind of trauma to the area. It's caused it to bruise and break, but the skin is still intact over it, but you have a lot of bruising. And another type of bruising is a hematoma. Another type of closed wound is a hematoma, where you'll have blood under the skin, where you've had an injury, but it's still closed. Okay. So make sure you're familiar with this wound terminology. This is in your book on page 1155, table 33.3, and there's also a video on this. Know these. Look these up and know the definitions. You may know a lot of these already, but if you don't, make sure that you're making sure that you know those definitions. All right. So, of course, intact skin is our first line of defense. Some other principles I want you to make sure you're aware of is the body responds systematically to trauma of any kind. So you're going to have your process of inflammatory process. We're going to go over that. But know that your whole body is responding anytime there's an injury or an open, even a paper cut. You have to have an adequate blood supply. So that's one reason if a person is dehydrated, they're not going to have enough blood supply to heal that area properly. We know that we need to keep wounds free of any foreign material. And so that's one reason we dress wounds. You guys are learning to dress wounds either last week or this week. And one of the reasons we dress a wound is to, number one, make sure we remove foreign material. Keep it clean and keep it protected so that it can heal. We also take steps to make sure that the moisture is balanced in any kind of wound, because all of that will allow that wound to heal faster, more sterilely, and heal up better, basically. Always use careful hand hygiene. Remember, hand hygiene is another step in keeping a person from becoming infected, and we certainly don't want to introduce an infection to that wound. Also, depending on the person's overall state of health is going to determine how well they heal. If it's someone who has a lot of comorbidities and they're already quite fragile, it's going to take much, much longer for that wound to heal because their body is responding to so many different stressors. And that's why folks with those comorbidities have a harder time healing. And we have to maintain nutrition. This is something I like to really focus on and make sure you guys see, even though it's down here at the bottom of the slide. As nurses, we are often the first and only person to notice if a patient isn't getting adequate nutrition. Say you've had a patient who's NPO, they're not able to tolerate food and fluids, they're healing from a wound, they're septic, they can't tolerate it, they vomit, they're not getting anything in. We are the ones who need to tell the physician or the nurse practitioner, hey, we need to get some kind of nutrition going for this patient. Maybe we need supplemental nutrition if they can tolerate that, some kind of high protein drink that they can take. If they can't tolerate that, maybe we need to look at getting IV nutrition, which is something we'll talk about in our nutrition lecture. But always be thinking about nutrition, because if we don't have proper protein, enough protein, we are never going to heal because our body can't create healthy cells. So when this is the phases of wound healing, this is that we go through, and I'll talk about them on each slide here. So basically, hemostasis is the immediate thing that happens. You get a paper cut, you start to bleed, right? After you start to bleed, your blood vessels will then constrict and they'll start clotting. After that, you'll start having a little bit of pain and swelling. And as you get increased perfusion to that area, then you'll start having some heat and redness. At this point, basically what happens is the clotting factors and the platelets activate and cluster so that you don't bleed to death. Because if that didn't happen, and in folks who don't have adequate clotting ability, they can get a tiny little cut and bleed to death from it. So this is a really important thing that happens immediately after an injury, even a paper cut. Your body sends all the soldiers in to clot things over and keep you from bleeding to death. Following that is the inflammatory phase. This usually lasts 2 to 3 days. This is when the white blood cell counts, such as leukocytes, head to the wound area. Leukocytes get there first. They eat the debris and bacteria. The macrophages come in. They start ingesting any debris that's in there. And they start putting out growth factors. The other thing that the macrophages do is they attract the fibroblasts to help fill the wound and start healing it. Cytokines promote repair by increasing this inflammatory response. And this is when you start getting the pain, heat, redness, swelling. You might have some pus or fluid coming out. You're going to have that mild fever, fatigue, and increased white blood cells. Okay? And you guys should all know these stages already. After that first couple of days, then you have the proliferation stage, and this is where your body starts repairing, regenerating. You have capillaries that grow across the wound. The fibroblasts are doing their work, putting down collagen, putting down connective tissue. The peak for this is 5 to 7 days, and this is that phase where everything's getting fixed and granulation tissue starts forming. During this 5 to 7 days, and this is after any type of injury, whether it's an incision or, this is the normal wound healing phase. So during that 5 to 7 days, during the proliferation phase, is when it's super important that you make sure they have enough nutrition, oxygenation, because you need both of those, nutrition and oxygenation, to get those cells growing, get that area perfused, get that area healing, and to support the healing process. The other thing you want to do during this phase, because you're just getting putting down all of these new cells and new connective tissue, is you want to avoid strain. So this person should not be lifting anything. If they cough, they should be splinting that cough. If it's a chest or abdominal wound, they should be splinting that cough with some type of pillow or support. If they have an abdominal wound, you may have an abdominal binder on them during this time. We want to do everything we can to keep those newly formed connections from busting open. And so this is one reason that folks who are having a lot of coughing, a lot of nausea, a lot of vomiting are at an increased risk of what we call dehiscence, the wound opening up. So be aware of that. Get them plenty of nutrition, plenty of oxygen, help them avoid strain to those tissues. And that may include giving an anti-nausea med so that they're not vomiting and straining that tissue. And then in the final stage, in a normal healing process, is about 3 weeks after the initial injury, but it can continue for months or years in a chronic injury. This is where we have new collagen. And scar formation starts to form. Now, the thing to know about scars is that they are 70 to 80% weaker than normal tissue. So just be aware of that. Anytime a person has a scar, they're going to have, it's going to be a vulnerable area for the future. Maybe you have a scar from when you were younger that you notice anytime you get a sunburn, that area has problems first or starts opening up. Scar tissue won't sweat, it doesn't grow hair, it doesn't, it's not as functional. But we are glad it's there because it is protecting us. So that is a normal healing process, okay? And that normal healing process, even in a surgical incision, should be done within 30 days. That is a normal healing process. And that is considered an acute wound when it takes days to weeks to heal. It's low infection rates, paper cut, surgical incision. It should be healed within 30 days at the longest. A chronic wound is a wound that experiences delayed healing for some reason. Chronic wounds can take over 30 days to heal, and they stay in the inflammatory phase. They don't move forward into the proliferation or maturation phase. They stay in that inflammatory phase much longer. And if you look at this slide, these are the factors that can cause someone to have chronic wound healing instead of the acute normal, quote unquote, normal process of wound healing. If there's pressure on that wound, it's not going to heal as well. You're not going to get blood to that area. If they're on bed rest, for example, that's one reason we get people up and moving so fast after surgery now. If they're dehydrated and the wound doesn't have enough fluid, because not enough fluid means not enough blood cells to go to that area and heal things up, you're going to have delayed healing. Maceration may be a term you're not familiar with. That is overhydration, someone who has a lot of drainage in that wound. We've got to clean that drainage out, or maybe put a drain in there to keep fluid away from that wound so it can heal properly. If it was traumatic, if it was an unintentional wound with a lot of bacteria, or if for whatever reason we have an infection to that wound, that is going to cause delayed healing. Any kind of excessive bleeding is the same principle. You simply can't heal properly if you've got too much fluid in that area, including edema, excessive bleeding. Things that can factor this as well are things like limited mobility, bed rest for those pressure issues. If you're wearing a cast, if a person has sepsis, infection, if the tissue started to die or keeps eroding and is not healing properly, people who are immunosuppressed with autoimmune disease, any kind of pH alterations, a person who's got COPD or bronchitis along with all of this will have a longer time healing because their pH isn't going to be normal. And we know that we need that normal pH for cells and wounds to heal. Think about folks, let me see if I've got another slide. Here it is. Think about folks who have reduced sensation. Maybe they've got paralysis or some kind of nerve damage, such as folks with diabetes. And also the poor circulation. If they can't feel their wound as well, they're not going to protect it as well. It's not, and besides all the other factors that keep it from healing as well. If you can't feel where it is, you're just not going to be, a person who's paralyzed perhaps from the waist down. They're not going to feel when they've been laying in one position too long, and that wound will develop and then perhaps not heal. So think about your patient's neurostatus. Think about, can they feel their body? Can they feel everything? Do they have good sensation? Especially, you will see this with diabetics a lot. They won't even know they've got anything wrong, and they'll come in with a big wound on their foot. This is one reason we teach regular foot care, regular look at your feet every day. What do you see? Because they may not feel a wound, but if they look at their feet every day and examine them, they can help. They can say, oh, that area is reddened. I can't feel anything, but I should probably call my doctor about that, right? So any kind of nerve damage, nutritional status cannot be overemphasized. We've got to keep people eating right, eating plenty of food. When they're getting discharged, ask them, well, what do you eat every day? Do you have money to buy food? Especially today, as expensive as groceries have been, people may not be able to afford adequate protein. So we may need to send them home with some type of protein shake to make sure that they're getting enough protein to facilitate wound healing. I think I mentioned everything else here. Some medications, if you're on steroids, those can inhibit healing. And so if you have someone who is, say, COPD and they have to be on steroids, they're not going to heal up as fast. It's going to take a while until maybe we wean them off the steroids, until we can get their their wound healed. We're going to skip the questions. You guys aren't here. So everything I just said, infection's a big one, hemorrhage, bleeding at the site. We're going to talk about each of these. I think I have slides for them. I'm trying not to ignore my slides. Let's see. Can't go back. So let me pause. So it won't let me go back. So I'm just going to tell you, infection is something you will usually see from 2 days to 1 week post-op. It's something that you can see before they leave the hospital, or they might see when they get home. So teach them the signs and symptoms of an infection. Tell them to look at their wound every day. Give them any information about keeping it clean. Hemorrhage, usually we'll see that in the first 48 hours. So that's something to just keep watching for. I always tell people, if you're having trouble keeping someone's blood pressure normalized, and they just had surgery a few days ago, even if you're not seeing blood come out of their wound or into their drains, think about possible internal bleeding. Because one of the things that I've noticed over the years is if someone is dehydrated and they're losing, especially if they're losing blood, you will have very difficult time keeping their blood pressure up. It will be up and down, and be trending down. So look at that, keep an eye on that. You may need to do a stat CBC to see what their hemoglobin is, even though it was fine yesterday and they look great. If you're having trouble keeping their blood pressure up, think about bleeding if they're pre-op, post-op. If their hemoglobin's okay, then you can start thinking about other things, but definitely think of bleeding first and ask for that CBC, because that first 48 hours is the time you're going to see some bleeding, and it may be internal. It may not be coming out on your drain, out of your drains, or out of your on your wound. Dehiscence. This is when the wound layers separate. If you've been in lab for your wound care lab already, or if you're going to be in lab this week for that, you will have a wound that looks similar to this one on the left. It's a wound that's dehisced. And basically what that means is the physician had it sewed up, it was looking good, and then the person, for whatever reason, they got an infection under there and it started to bulge and popped open. Sometimes this is a person who's having a lot of nausea or vomiting, they're coughing a lot, and you just haven't protected the wound properly, and it will dehisce. So dehiscence is when the wound edges, the partial or total separation of the wound layers. When you've got unhealed wounds, they're not as strong, remember, until they get into that 30-day phase. So you can definitely have this happen. One sign to look for wound dehiscence, if it's about 4 to 5 days post-op and you're noticing an increase in serosanguinous fluid from the wound, that is a sign that you may be having a dehiscence coming soon. Because if you start having increased secretions 4 to 5 days out, normally you start seeing them decrease over time. So if you start seeing increased secretions coming from the wound, especially serosanguinous secretions, that is a sign that you could be looking at a pending dehiscence. And you'll see this when someone gets an infection. Maybe they're obese and the wound, the stitches just aren't holding, and there are layers of stitches, but they're not holding. They've been straining to go to the bathroom. They've been coughing, vomiting. Maybe they're a smoker. With smokers, we have poorer healing. And sometimes they're on anticoagulants, which will cause more blood to go to the area and can cause it to dehisce. So watch for that increase in serosanguinous fluid from the wound around days 4 to 5. The one on the right over here, also, if you have a dehiscence, you'll sometimes hear a pop too. If they're coughing and you hear a pop, take a look at their wound and see if it's opened up. The one on the right on your film here is called evisceration. This is the most serious complication of dehiscence. This most often happens with abdominal incisions, and this is when the wound completely separates and the organs come out. This is a medical emergency. You need to stay with the patient. You need to put them in a low Fowler's position. Cover the wound with sterile moistened towels or gauze that is sterile, whatever you have with you. Use normal saline to make it moist so it's not just dry, but cover it with some type of sterile, either a towel or a dressing. moisten it so that it doesn't stick to that bowel. Keep them in PO and have stay with them and either call a rapid response or have your charge nurse call the provider immediately, because if they have an evisceration, this is an emergency. They need to go to surgery right away and have that wound closed back up. Okay, and again, it's the same culprits that we see in a dehiscence. It's just deeper than a dehiscence. The dehiscence will be a partial separation of the wound layers, and with an evisceration, it's basically every layer has opened up, and now you've got bowel sticking out. So again, medical emergency. Stay with them. Cover the wound with moist, sterile towels or gauze. Keep them in PO and either call a rapid response or call the physician right now because they need to go back to surgery. And you're keeping them in PO because of the pending surgery that they're going to need. So these are both things that you'll see. Another complication that you'll see is a fistula formation, and I don't have a picture of that, but a fistula is basically when there's a hole that occurs between one part of the body and another. Sometimes you'll see fistula formations in folks who have severe ulcerative colitis, and their bowel starts forming a fistula with their bladder. So that's what a fistula is when your body creates another opening somewhere because the tissue has been degraded, and you obviously start getting problems with parts of the body being in touch with each other that shouldn't be. So all of those are complications of wounds, and I wanted to have these pictures for you for these two. So I'm going to end this video here, and I'm going to do another recording starting here at pressure injury development. Thanks, guys.